Commissioning Committee. My name is Hein van der Wildenberg. I'm a non-executive member of the Integrated Care Board of Norfolk and Waveney. Today's meeting is a meeting in public. It is being recorded and will be available on YouTube afterwards. A special warm welcome to Debbie Bartlett, who has succeeded James Bullion, and she will be chairing this meeting going forward. But we agreed for a first meeting I would do the chairing, and then from there on Debbie will. But Debbie, maybe you want to say a few words by way of introduction? Can you hear me, Debbie?
Sorry, the County Hall Wi-Fi chucked me out for a minute then, Hein. So
maybe a few words by way of introduction. I was welcoming you to the committee.
Thank you. Sorry about that. What timing? So Debbie Bartlett, Interim Executive Director for Adult Social Services, taking on the role from James Bullion. Delighted to be taking on his role here. Hein's in the chair today, though, because there's a lot on here, isn't there? But a really good opportunity to listen in and see what's going on. So thank you.
Thanks, Debbie. As the agenda says, I took a chair's action in June. That was to extend the deadline from June 30th to July 31st for practices to sign up to recommissioned LCSs and to extend current service specification till the end of July. For the agenda today, you may have seen item 9 is being deferred, so that is coming to a next meeting. It takes me to apologies. We have received apologies from Hilary Byrne, Andy Bell, Jason Stokes, Tony Dean, and James Reeder. I think that's the list as I have it. Sarah, have I missed anyone?
I haven't had any more at my moment.
Okay. And Tricia?
Please, could we note the apologies from Karen Watts, who's on annual leave, and Paul Benton was attending this meeting, but we've swapped today, so You've got me, Hein.
Yeah, very, very good. And I think Steve, of course, also sent apologies, and I see Hilary is here, so I was misinformed, Hilary. Steve, of course, is not here, but Stuart White, I believe, is attending the meeting. Yeah, and he's on the call. Very good. That takes me declarations of interest. You've seen the list in the pre-read. Just asking if anyone needs to highlight an interest in view of today's agenda. Take it as a no. That takes us to the minutes of the previous meeting. As per usual, I will take them in their entirety. Is there any comment as to accuracy of the minutes? No, many thanks, Sarah, for those. Then the action log. I'll just run through it. Action 148, that item is on today's agenda, so can be closed. 149, 150, I think Jade Robertson will touch upon those in today's agenda items, so I think we can bring those to a close at the end of the meeting. 151 has happened, and the last two are not yet due, so there's a quick run through on the actions. Just checking if there's any comments from anyone. No, very good. That takes me to the forward planner. Sadie, I'll hand over to you.
Thank you, Hein. So just to note on the forward planner for this month, as you can see, the agenda is rather full. So the PCN DES item, which we had deferred, we've listed for the agenda for the first operational delivery group, which will be happening later this month. We'll run it through there, and that will, of course, be reported to committee through a regular report. You may also have spotted that the dental short-term plan is listed for October. We have been saying that our plans will be concluded in September, our short-term plan, and we aim to do that. we are therefore likely to be able to bring that forward into the September meeting with a fair wind. And we still intend to bring our March longer term plan next year.
Thanks, Sadie. And we could use a bit of fair wind in dentistry, so hopefully that will work. Any comments from anyone on the forward planner? No, many thanks, Sadie. We'll stay with you for the risk register.
Thank you, Hein. So we have a couple of risks that are rated red that you'll be able to see. So I'd just like to highlight those, I think. The PC14, which is on the BAF as number 16, which is the resilience of general practice. This month we're able to update that we've invested £788,000 in our quality support and stability payment that we offered to practices throughout winter, and in particular in response to the twindemic of flu and COVID, and also the strep A situation that we had November, December time. And that benefited 67 practices in total, so roughly 2/3 of our practices. There were two parts to the QSSP, the Quality Support and Stability Payment, and we are in line with the normal timeframes for the Impact and Investment Fund. We are calculating that payment as we speak, and we expect to make that next month to practices, so we'll be able to provide a further update as part of the next risk register. A number of us attended the Health Overview and Scrutiny Committee in Norfolk recently to talk about access, and I think it's fair to say that HOSC members did understand the issues facing general practice, and we're really disappointed to hear about some of the abuse that our practices had been experiencing, and we're very supportive of them in that. Secondly, I'd like to refer to PC 18, BAF 18, which is the refocused risk on dental services. You'll see that as agreed, that risk has now been refocused because the transition has been completed. We are on track for our plans that we've committed to, our timelines around those, and we can update further to last month's meeting that the urgent care service we had proposed for dentistry has now been approved, and we are proceeding with that offer, which we should be making very shortly to dental providers. But we are quite concerned about the resilience of dental services in Norfolk and Waveney. I think everybody is aware of the situation. We don't have any NHS dentists currently accepting new NHS patients in Norfolk and Waveney, and we understand it's the same in our neighbouring ICB of Suffolk and North East Essex as well. So really important that we continue our work on our short-term plans, and we will be bringing those here for discussion. But we're getting fantastic engagement from our dental providers, and really insightful comments that will help us formulate our plans. The only other item I wanted to pick up on was the learning disability risk, PC6, and we had managed to reduce the score last year, as you will know, with our performance progressing well. We do have some anomalies between the nationally reported data and our locally extracted data, and we're working on that with the national team, and we think we've identified roughly where that discrepancy is coming from, in that it picks up practice-based activity but not primary care network based activity. But we do know that the national team do not plan to reissue those figures, so we will have to continue to explain the difference when we're talking about them locally. Our monthly delivery so far is slightly behind trajectory, so Shepherd's team is watching that very closely, and will determine next time whether we're going to recommend a change in risk score for that risk. And I think I'll probably stop there. I can see Bill's got his hand up.
Thanks, Sadie. Opening up for questions and comments, and Bill, indeed, over to you.
Just on this issue of national not recognising the stats in the same way, is this unique to Norfolk and Waveney, or is this a national issue?
Yes.
So everybody's got the same issue.
Yes.
Fine. Okay. Thanks,
Bill. Tricia.
So just picking up on that point, I totally note the positive progress that's been made around learning disabilities health checks, and it's imperative that we don't lose traction in this year. So I really welcome Shepherd and his team focus on the health checks to make sure that we're working in the right direction to ensure those with health inequalities are being championed in our system. But my point was slightly different, if that's okay, Hein. We've just had the forward planner and we've just had the risk register, and I know on the agenda we've got a focus on workforce, which I really welcome. But in the last week we've had the publication of the long-term workforce plan, and I wonder if it would be prudent to do a triangulation piece with regards to what we're doing here to recruit and retain, and what are going to be the recommended areas, strategic areas that we need to focus, and just ensure that we've got a work stream on all of those areas. And then we can build a work program and a delivery plan against those particular areas. So it might not be for the next meeting, Hein, but I just think it would be worthwhile us putting a line in the sand, really.
Yeah, I think that's a very good suggestion. So ask Sadie to include it in the forward planner and work with Jade and others to find the right timing for that. Thanks. I've looked at the risk, and PC18 indeed stands out, and I think it's been the right decision to change the emphasis in the risk. And from what you said and what I've seen, I think the risk scoring I would think is appropriate there. So just by way of support. Are there any other comments or questions on the risk register? So in the past we've been asked to note it, but I think in line with the internal audit, we're now also asked to approve the risk scoring. So just go by exception. Is there anyone who doesn't agree with the proposed scoring of the risks? No, I take it as support, and we'll minute accordingly. Many thanks, Sadie. That takes us to item 7, around 2 NHSE publications in recent months, and then the task that rests on the various integrated care systems to pick that up. So the delivery plan for recovering access and better working together. So I think Sarah Harvey is with us. So can I hand over to you, Sarah? Good afternoon.
Good afternoon. Thanks, Hein.
Yeah.
So thank you, everybody. I will take the paper as read. I recognise there's a lot of information included within there. I just wanted to highlight a few key progress updates in relation to the actions to support delivery. So in the last week, we have received all of the draft PCN capacity access and improvement plans, which are currently undergoing a review process. and we have submitted our system bid for funding to support 39 practices to move to cloud-based telephony in line with the asks of the plan. And we're waiting to hear back from NHS England on the outcome of that bid. And since the writing of the report, the transition funding guidance has been published, which outlines how practices can apply for transition funding to support the move to the modern general practice access model. And we're picking up the requests for access of funding through the review process of the capacity and access improvement plans, and we'll have separate conversations with practices where we feel additional support could be provided to practices. So they were really the key things I wanted to highlight from the report. As I say, there's a huge amount of detail in there, so if anybody does have any questions they would like to ask, then I'm open to them.
Thanks, Sarah. I would agree. There's a lot in the note. So let me check any questions or comments. Sarah. Andrew.
Yeah, thanks. Hi, Sarah. I just wanted to feedback. This is for Healthwatch. There's a huge emphasis in that paper on access, which seems to be the political will always. And I want to balance that with the, as I always go on about, I know, the huge importance of continuity. And I just want to illustrate that with for patients. I went to a village hall meeting a couple of weeks ago, which had 200 residents from a village of population of just over 2,000, so it's about 10% of the population attended. Now, the good thing was that there was no rudeness or aggression, but there was, I think, sadness and even a little bit of fear about, it was about access, but it was balanced with a huge desire for continuity, not only from GPs, doctors, but from practice nurses, from midwives, everybody really. And I just wanted to make the point yet again to make sure that that's appreciated and included in any planning, because it does get lost with the emphasis always on access.
No, completely understand, and I think it's a really valid point to highlight. And I think sadly it's one of the potential unintended consequences of the plan. Whilst the focus on access is important, like you say, it's very important not to lose sight of continuity. And we will be making sure to reflect that within our system response to the plan.
Thanks.
Thanks, Andrew. Sadie.
Thank you, Hein. I just wanted to add, I think it is included in the report. We part of the report today includes a requirement for us to continue to work on our interface with secondary care and other NHS providers. And Sarah is coordinating a system response to that. We were already working on that as an ICB with the trusts, and we're supported by our contracting and procurement team with that. We also have regular meetings with the local medical committee. And part of the requirement set out in the guidance is that all ICBs should report progress on their system plan and their interface work at their ICB board meetings in November, and then an update in March. So I think it's what we need to do as part of that is make sure that it's listed at committee, and we bring it to committee for discussion first before we take it to ICB board. So we'll make sure that that's included on the forward plan, and we're also encouraging our trust partners to do the same, so that they consider it in their board meetings before it's reported by the ICB board. So that's just something I wanted to add. Thank you.
Yeah, many thanks. That addresses one of the points I had. Thanks, Hilary.
Thanks, Hein. I think the plan's quite interesting, and I think it's had quite a mixed response in primary care, because I think when you look at the diagrams in the plan, the concern is that you'll just push the problem further down the pathway, and if you don't have enough people to actually provide the capacity, and you don't have enough space to house those people to provide that capacity in primary care buildings, then actually you're just moving it further along by a step, and you're not actually producing you know, the improvements or the care that you want to be able to provide to people. I think there are real concerns about raising expectations, and that this will increase expectations and potentially increase the difficulties people on the front line are facing in terms of patients who don't feel their expectations are being met. So I think there's some interesting things in it, but I think the key is going to be how much of that is actually deliverable and how much of that is actually going to make a difference with all the constraints that we know around workforce and premises and those other aspects.
Thanks, Hilary. And I think it's good when before the note is sent to the board that the full spectrum of views is being weighed into the note. So maybe, Sarah, you can keep it in mind when you're preparing the, which will come to PCCC first before it goes to board.
Yeah, of course.
Thanks, Hilary. And one specific question. Towards the end of the note, it mentions 3 types of offer for PCNs to help improve with, at the time the note was written, a certain uptake by certain PCNs. Is that ongoing until when do PCNs have time to put their name forward?
So yeah, so it's practice level program, and there is a PCN program as well. At time of writing, those numbers were correct, but the cohort C of the improvement program has just been launched, and while we review the PCN plans, if we feel there is like, as I say, if I feel there's a need for additional support, or where we feel a practice would benefit from participating in one of the support offers, where they feel able to in terms of the time that they would have to commit to the plan, we will have that discussion with them through the review process.
Okay. Good. It's here for noting, and as Sadie explained, we'll see a few times back at the PCCC how it progresses. Naomi, sorry, didn't see your hand.
That's fine. Just wanted to feed into that last point about the opportunities to practice for the improvement programme, is that it is very intensive and uses an awful lot of practice time to engage. And whilst there may well be some really good learning outcomes from it, actually what practices are struggling so much with is capacity. And so a lot of the practices that may well benefit from this are just not going to have the capacity in place to fully engage with this programme. And I really feel that that needs to be noted by PCCC and acknowledged by the ICB, that there will need to be a focus on how we can all work together to enable those practices that need this input to actually be able to partake appropriately.
Yeah, thanks, Naomi. And I think that's a really valid point, and something that we've actually fed back to NHS England on behalf of the ICB. So recognising where the practices who perhaps most need the support offers are those that can't commit to it due to, like, as you say, capacity constraints. So we fed back that it would be helpful to have some smaller, more bite-sized sessions that we could signpost those practices to, and waiting to hear back whether there's anything that can be done about that nationally.
Good. Bill. You're on mute, I think, Bill.
Just on that point, how helpful is this then? Because if the areas and you know there is a, you know, is this the right approach to dealing with the issue? And how much authority do we have as a committee to influence that, or do we just note it, or can we shape it in any way, or put in a request to the ICB, or, I mean, how much of this is our responsibility as a committee?
Sadie, you want to weigh in?
Yeah, I think it's an interesting question. I mean, this has obviously come down as one of the 3 priorities of NHS England. So they've chosen elective recovery, urgent and emergency care recovery, and access to primary care, aka general practice, as their 3 national priorities. So this guidance has come down to us to work with practices and support them. But I think it's fair to say that it doesn't apply equally everywhere. And I think it's for us to support and work with our primary care networks to respond to the needs of their local population and to support improvement where improvement is needed. as has been mentioned, there are potential unintended consequences from some of these policies, but there are some really good parts to it. So cloud-based telephony, as an example, is great that we get more funding to take, because you know it's a really expensive process to go through, and there's some fantastic learning there through the improvement programs for those practices that are able to participate. And we are looking at what our local offer can be. I think the main opportunity for us as a committee is to, I suppose, shape and influence our system level plans around this, which allow us to take the national guidance and to determine kind of how that applies in Norfolk and Waveney, and provide that context and support to our practices accordingly. Because, you know, albeit some of it may be contractually required, not everything, it's not a one size fits all in general practice. We have very different populations across the whole system, and we have different levels of resilience in different places as well.
I think that's really useful to hear. Sorry, if you don't mind, Chair.
Yeah.
But so would you know? I take your point about should we be shaping it, and is that a decision that's made here, or is that decision made somewhere else?
So the primary care committee will be where we bring the system plan. So we'll bring it in draft for discussion, and then we'll approve the final version, and that will then go on to the board in November and January. So we have the opportunity to shape our system plan before it goes to board.
Okay,
yeah.
So if we're then saying that, you know, the telephony offer is particularly useful and is something that we would like to see as a priority, but we're worried about capacity issues, could we make a request in this committee that that is considered as part of the more localized approach of the plan here? And if there are any other particular areas that people would like to draw to the attention as the plan is further scoped, then we can add them. I mean, would that be a sort of suitable response from the committee?
Well, my view is that it would be. And I think, as Tricia mentioned earlier, we have a fantastic opportunity with the workforce plan, with the access planning, etc., with our joint forward plan and our priority around the resilience of primary care, to look at how we triangulate all of these different approaches and present them both here and to board.
Yeah, I agree. I think a lot of things come together, and I see a few hands up, but maybe Sarah, you mentioned the first practices have started this intensive offer. So it would be good to hear, we'll probably hear what Naomi was saying. It has a lot of call on people to take part in it, but there might be other insights as well, which would be valuable for the committee to hear as they ascertain the system access plan. Naomi.
Yeah, I mean, Sadie has said a lot of what I was planning to say, but I think a lot of this for the improvement programs is almost should be seen as stage one. It's identifying what the issues are, it's identifying what the opportunities are, it's identifying what the main risks are. And then what needs to happen is the next stage, where it's okay, and what? So what support is needed, what is within the gift of the local system to support with, and what is within the gift of the PCCC to agree. So all of this needs to feed into the workforce plans, the access plans, and everything else that will be the enablers of actually providing the required outcomes of what this training is identifying as real issues and practices. And as we know, most of it is capacity. There's just not enough workforce. So workforce is really going to need to be the priority of any plans put in place locally.
Yeah, thanks. Shepherd.
It was just to echo the response from Sadie around the offers. So I think it's clear that not all our practices will fit into the national offer. And it's clear from the access and improvement plans that we are receiving so far. And that presents really a great opportunity to pull through what is coming through these plans to develop our local offer, which will supplement some of the national programs and also help with some of the already work that we're doing to support practices that are at risk. So I'm really looking forward to that point where we've reviewed all our plans. Then we can start having the meaningful conversation around what does our local offer mean to the areas that have been identified from those.
Thanks, Shepard. Tricia?
So I think this is a really good conversation, actually. But the bit that's missing for me is we're talking about the individual practices and we're talking about the strategic impact of the ICB in the spirit that one size doesn't fit all, because practices will be in a different place. I think the opportunity to use the strengths within the PCNs needs to be noted as well as a support mechanism for some of these initiatives, because learning from best practice of what's been operationalized in one practice may benefit another. And I suppose the sweet spot for me as an ICB is how do we build in the headspace to allow for people to take control of some of the capacity plans that they will have individually at practice level and make them a reality. My point was let's not forget the patients in all of this. And we need to think about the communities and the impact of any of these initiatives on access for the individuals. So for many of our communities, they may not be digitally enabled. There are other things that we're going to have to do to make sure that they are being cared for within the new ways of working. And can I just say, from the perspective of continuity of care, Andrew, you mentioned that earlier. That for me is something that is a very difficult challenge in the current system that we're operating in. But from a patient point of view, continuity of care is probably the most important element. We will have some opportunity to enhance the not having to tell your story more than once we've got the ESR in place, but that's a long way off at the moment. But I think we need to keep focus very much on our patients as we talk about all of these initiatives, because that's the reality, the experience that they're receiving.
Thanks, Tricia. I would echo good discussion and lots of things to take away from that. So many thanks, Sarah, and we'll see you several times in the months ahead with
Thank you.
access plan and the likes. Thanks for joining. That takes us to item 8, COVID antiviral supply, and Sharon Gardner is with us. Hi, Sharon. I hand over to you for a brief introduction.
Thanks, Hein. Good afternoon to the committee. So in terms of the report, I'll assume the report has been read, but just to highlight some key points for you. To date, the management of vulnerable patients who have tested positive for COVID has been through our COVID medicines delivery units, otherwise known as CNDUs, in the 3 acute trusts. This has been supported with national identification, notification to patients of available treatments. In late 22, as we moved from a pandemic management of COVID, there was a national direction that the management of these patients should be moved into primary care and should form part of business as usual practice. It's later announced that this would need to be in place from the 27th of June of this year, when the national notification documents were going to be decommissioned. After engagement with our local stakeholders, LMC and ALPC, due to the increased clinical upskilling that's required with these medications for the prescribing and dispensing, there was resistance to a business as usual approach, so other options had to be explored. The final outcomes of these conversations was a procurement of the triage and assessment of the patients through our out-of-hours provider IC24 and NHS 111, IV oral antivirals for for the time being will still be managed through the CMDUs, as the transition of this to primary care is slightly more complicated due to the delivery arrangements of the medication. And if oral antivirals are requested, then this will be managed through a community pharmacy strategically commissioned service. Community pharmacy pathway does take note of the current workforce and resilience challenges and does have the backing of the LPC, who will support with the engagement and confirmation of the 25 required pharmacies. Just to note that the money being used to support the above pathway is non-recurrent, so this is a transitional pathway, and the business as usual model must be continued to be explored with stakeholders. It's an aspiration that as an ICB we would have a business as usual model from September 24, which is in line with our current out of hour contract with IC24 ending. A working group will remain in place, or is remaining in place, to confirm the IV pathway by the end of August, and also will remain in place to support the engagement of a transition to a business as usual model over the coming year. NHS direction regarding the triage and assessment part of the pathway will form a key part of this as a future piece of work. The transition pathway discussed for all three elements has already received approval from the Plan Care and Medicines Management Working Group and the Executive Management Team in June. Requested of the committee to note the procurement of IC24 as a transitional model, whilst the BAU is continue to be explored, and that the IV element of the pathway to remain in the acute trust for a short period of time, and also to approve the use of ring-fence money to commission 25 strategically placed pharmacies to provide an oral antiviral holding and supply service. That's a very brief description of the paper, and I welcome any questions that anybody may have.
Many thanks, Sharon. So the ask of the committee is approval of the transitional arrangement in the expectation that business as usual will commence per September 24. Is that correct?
Yes.
Yeah. Thanks. I'll open up for questions or comments for Sharon. Lauren?
Yeah, I'd just like to note the thanks from the LPC for the pragmatic approach that the team has taken in drafting this paper and putting forward the proposals, particularly given our representations at HOSC last month and the acknowledgement of the workforce pressures at the moment that community pharmacy are feeling.
Thanks, Lauren. There's no questions. Are we happy to approve as committee? Good as a yes. So many thanks, Sharon,
Thanks,
for an
Hein.
excellent note. Thank you. As mentioned, item 9 is deferred, coming back to a next meeting, which takes us to item 10, primary care complaints and contacts. And I think, John, you will guide us through that.
Yes, yeah, and for those of you, thanks, Hein. For those of you that don't know me, my name's John. I'm the complaints and inquiries manager for the ICB, and Sadie asked me to bring a report here today, which is primarily talks through the contacts the ICB received during the last financial year, 22-23. I'll take the report as read, but there is some highlights that I'd just like to go through. I think, as you can see from the numbers in the report, the majority of our contacts, although we're a complaints and inquiries team and we're often badged as the complaints team, the majority of our contacts aren't. In fact, they're in the form of people contacting us with informal concerns or questions. There is an expectation actually that in the last financial year, most of those inquiries would have gone through NHS England's contact centre, but the team have absolutely tried to resolve those issues without the need to pass people from pillar to post where they're able to. But it does mean that as of the 1st of July, which I've detailed in the report, that the ICB took on the handling of complaints and concerns fully for primary care services in their entirety, which transferred to us, as I say, on the 1st of July from NHS England. Patients, it's a subtle change. Patients are still encouraged to contact the provider to complain to in the initially, but if they wish to complain to the Commissioner of the Service, that's now fully integrated into the ICB's complaints team, and that was previously NHS England's function. So I think the contacts that are reported in this particular report, it's really reasonable to think that those numbers are going to increase exponentially over the next few months. And last week was the first week where we really saw an upturn in numbers, because obviously it was, the first week that we'd taken it on. We definitely saw an upturn in formal complaints about primary care services. We certainly heard people's feelings about dental services, which I know has been previously talked about at this committee. So I think probably in a few months' time, we'll have quite a lot of intelligence and feedback that hopefully will be able to be used to improve services and identify trends. Just to offer some reassurance about that upturn in volumes, 2 members of staff have tupied over to the ICB from NHS England to help manage that additional volume. We have inherited a backlog of formal complaints from NHS England, some of which date back to August last year. So at the moment, we've tasked the staff members with making contact with those complainants affected and really trying to get those cases moving as quickly as possible. And we've seen some movement in that respect in this week as well. In terms of just the last year, the trends we saw, as you can imagine, there was quite a lot of feedback around access to appointments, either via the telephone or face-to-face. That definitely remains a big area of inquiry and sometimes complaint. But also, and this kind of surprised me actually, people not receiving a response to their complaint, either from the practice or NHS England, came up quite a lot. So as I've detailed in the report, we're looking to establish really good working relationships with all primary care providers and identify opportunities for improved complaints handling over the next few months. We think having all of the complaints responsibility locally will provide better opportunities and chances to resolve cases early. I did last month, I delivered some bite-sized training for GP practice managers around complaints handling, which seemed to go down really well. And definitely from the practice managers that were in attendance, there was a real desire to work more closely. And I think that, yeah, once we improve those relationships, which we're looking to do and establish those over the next few months, then yeah, hopefully we'll have quite a bit in terms of efficiencies and, ultimately better outcomes for patients and complainants. So I think those were the main highlights, but very happy to take any questions you have.
Yeah, many thanks, John, and not just providing a view on what last year, but also the trends you see emerging in this financial year. So any questions or comments for John? Debbie.
Thank you. I was interested to know, presumably these ones that actually come on as complaints in the way that you've set them out in this paper are the ones that haven't been able to be resolved locally. Is that right?
Not entirely. So they may have tried some informal steps to resolve it with the practice, but people absolutely have the right to either complain to the provider directly or the Commissioner of Service. So some people will choose to just go directly to the Commissioner, and that's typically when we will get involved with the formal complaints. But yeah, so you can do one or the other, but not both.
But presumably there is a part of your bite-sized training is to encourage some sort of local engagement and to resolve it at
absolutely,
rather than default to the process.
100%, and lots of that is steps that are quite simple. So just pick up the phone, invite them in if that's appropriate, because very often people just want to be heard. They just want to get it out of their system, and actually sometimes that's enough, or it will be enough to take the sting out of the complaint, so the practice can perhaps focus on getting on and resolving it. So yeah, I mean it was very well received, and I think yeah, hopefully those slides are available for all practices now, because I know that all of them couldn't attend, but it's something that we'd be keen to deliver at localized levels as well, perhaps with a bit more of a local flavour, and for other primary care providers as well if we can.
Thank you.
Thanks, Debbie. Andrew.
Yeah, John, thanks for that. I was slightly surprised to hear that NHS England handed you over a backlog that dates back almost a year.
Yes.
Which I'm sure the public would find very surprising. But I'm sure that will get better when things are dealt with locally. But do you have a broad time frame for when people should get a full response from the system? And I don't mean with horribly complicated things, but just with an average.
So I think that's quite tricky to answer in specific terms, Andrew. What I would say is that we've inherited probably about 40 to 45. That's already down to 35 with some proactive phone calls to complainants to actually understand issues and see actually what are the residual areas of concern, given that some months have elapsed. There are probably about a third of those where we actually have the information to get on with it and start drafting complaints responses, but NHS England's complaints team was impacted by quite a lot of capacity issues, so we're picking up the result of that, and I think they had some difficulties in terms of recruiting staff as well. We don't have that issue, you know, kind of we're pretty much at full complement, so we can start to crack through those. There are others where I think, you know, it's not worth dressing it up. There may be significant delays because they are in a pot awaiting clinical review, and the capacity of clinical reviewers, which is something that the NHS England team continue to provide, is limited. So we're having a triage of all those complaints to understand whether we feel locally that actually they definitely need a clinical review, or whether the responses are robust enough to start to progress those. So, I mean, look, I think to answer your question in a very short way, rather than me blathering on, I think, you know, over the next few weeks, we'll have a much better idea on it. And I would expect those numbers to be in single figures, you know, kind of in 2-3 months.
Thanks.
Thanks, Andrew. Tricia.
I just wonder, going forward, John, for reporting to the committee, and I'm not asking a definite question, I suppose, is just when I look at Appendix 1, if I was registered at a particular practice and I saw the numbers of complaints in comparison to other practices, that might make me anxious. And it would be useful to understand whether it's comparative against list size. And that may not be something that you can report here, but I think it would give a much more measured understanding of the level of discomfort in those practices, in the way that the processes are working. So maybe just to take home, if you wouldn't mind, John, and have a think about how that could be represented going forward.
I think that's a really good point, Trish, and I think the contacts that are highlighted in our report are only the contacts that the ICB have received. So what it doesn't factor in is actually how well engaged some practices are with their communities already. So they will probably handle the lion's share, and there may be other practices that are a bit earlier in their journey around that, and that may be where we're having additional contact. So yeah, I can absolutely take that away and have a good think about it.
Thank you, John.
Thanks, Tricia. Naomi.
Yeah, I was just going to say, I think another sort of learning and outcome of this is building on Hillary's earlier point about patient expectations, but also understanding of the system and how it works, and how much of this could be supported to minimise complaints by all really focusing on patient education and understanding of the system, but also practices making sure that individually they're making patients aware of how to access their services, how their queries will be dealt with, just to make sure that patients are a lot more informed, because sometimes that can lead to complaints more because of a misunderstanding of how it works rather than there was an actual issue. So I think that's something to look at the trends and see if there is any more sort of public engagement information sharing that could help patients to really understand and navigate the system.
I think that's a really good point, Naomi. I think it's one that we talked about as a team the other day, actually, not so much necessarily with a primary care flavour, but actually across the board, that the contacts that we're receiving in our team are representative of questions that will be asked in communities, you know, kind of all over the place. And so we've just started a new process with our comms and engagement team, so that every time we receive a contact, we're going to start considering, could that information have been published somewhere? Could it have been on our website? Could there be a bit more, you know, proactivity in, you know, practices or providers? So it's definitely something on our agenda, and I think you're on the money.
Thanks, Naomi. Yeah, very good report and discussion. John, one suggestion I made to Sadie, going through today's agenda with her, is given sort of the avalanche of inquiries you're expecting because of the increase in scope, it might be good to get sort of a 6-month overview for this committee. That helps us to sort of see what the dynamics of the additional services brings for you, and you can also consider some of the points Tricia mentioned for the appendix. Many thanks, John. Excellent update. Look forward to seeing you in a few months' time.
Thank you.
That takes us to item 11, workforce and training update. I see Jade has joined us, and Jade, workforce has already come up. It won't surprise you a few times in the discussion already. So I'll hand over to you.
Thank you. So I'll take the paper that has been read. Some key highlights I wanted to really draw the committee's attention. So I will be proposing to close action 149 and 150 based on the report and the updates I'll give today. So as you'll see, we have carried out a health and wellbeing survey across all of the 4 sectors of primary care. The actual return response rate is we had 244 responses across our 4 primary care sectors. We're currently analysing those results, and we'll be able to present in a virtual dashboard the findings from that to help support some of the implementation of the work that's taken forward. We'll be also introducing a health and wellbeing fellowship, which is an 18-month program to focus on and look at that, our overall supporting the ICS's health and wellbeing strategy, which primary care is featured heavily into that. The other element was the training needs analysis survey that we carried out across general practice. Really good uptake in terms of that, and part of that requirement, as you probably would see in the long-term plan, is obviously focusing on training. So that's one of our key elements within that that will be supporting that piece of work. We need to provide with back to NHS England at the end of this month the primary care, and when they're referring to primary care, currently we're only funded for general practice, so we'll have to make the committee aware of that for CPD training, and that's not all roles either. So GPs aren't funded within that CPD training, and non-clinical staff, as well as some additional role staff members. But what we're looking is the entire requirements across general practice in terms of their training needs analysis, and we'll be looking to support those roles, whatever role that you're performing within general practice, through a CPD plan. We will be also proposing in Q2 and at the start of Q3 is we're just going to do a training needs analysis for the other 3 primary care sectors. So we really want to understand what the requirements are from dentistry, community pharmacy and now optometry colleagues, so we can put a robust CPD plan to help support them within their pathway. We also would note that we have actually launched our social media platforms, and that's to promote all the training and education, plus the recruitment opportunities for the 4 sectors of primary care across Norfolk and Waveney. There has been a small growth, if I refer just to general practice, in terms of our workforce numbers. So you'll be able to see that we actually have had an increase in our GP numbers, first increase since December 22 across Norfolk and Waveney. But generally, as you'll be able to see, our GP trainees are increasing significantly, 23% growth, nursing colleagues of 2% growth, but our biggest growth is our direct patient care, which continues on as well of that. Sadie's already highlighted about some of the programs we've done in terms of the workplace violence and behaviour from the public. So we have actually put a crisis prevention program in place. We did test that out with a few practices, particularly within the Norwich area, but we will be looking to roll that out across the system, but to cover the 4 sectors of primary care as a whole. So I'm just working with our system colleagues to put that in place, which obviously will help support our entire primary care workforce. One part of the elements within the long-term plan is to look at our training requirements, and I will have to say Norfolk and Waveney are actually leading in terms of general practice across the east of England for our training practices. We've actually significantly increased our practices, so with 81% of our practices are now a learning organisation. If we compare this time last year, that was at 53%, so a significant amount of work that we've done in terms of increasing our educators and obviously our learning organisation placements. One of the things I wanted to highlight was a comment that Hilary made last time in terms of how we support our additional roles and also the supervision. So I just wanted to highlight and address that one. Across Norfolk and Waveney, just to give you some figures, we've actually got 19 practice supervisors and mentors across the system. Now, I appreciate that doesn't cover the entire complexity of Norfolk and Waveney, and part of their role is to support additional additional roles within that. We have got a plan to look to increase that, but also we'll have to say our overall GP training support vision to support newly qualified GPs, as well as our training grades, has increased by 35% across Norfolk and Waveney. So our plan is to continue focusing our efforts to increase that resilience to support, plus the additional roles, but also our trainees coming through as a result. And I'll be working very heavily with Sharon Kroll, who is our ICS clinical lead in terms of our training and education placements. So we've been very much working together to make sure we've got a fully robust system to help also support primary care. In terms of Action 150, which was about our community pharmacy integration work, we've actually introduced 3 primary care network integrated leads across the system, and we're also looking to recruit a further 2. So we will have one community integrated lead to help support that relationship between general practice and obviously our community colleagues. We have 4 student placements happening across Norfolk and Waveney in terms of the summer placements, but also we are also increasing our undergraduate placements within community pharmacy from September. So that's something, a piece of work that we've been doing. Finally, I just wanted to talk about dental workforce in particular. So in the next update back to the PCC, there will be quite a bit of a significant focus on what we're doing in terms of our dentistry workforce. As you appreciate, I'm trying to scope and work with our colleagues across the dentistry industry to really understand the appetite of what would support them in terms of their recruitment and retention, but also their training programs. So the main focus going forward will be looking at supporting international visa support in terms of dentistry workforce, our learning organisation growth, because as you appreciate, currently we've only got 6 foundation training practices across Norfolk and Waveney, so a really big emphasis in trying to increase that uptake, which also supports the long-term plan vision. And then also looking at our retaining and recruitment drive into our dentistry workforce. So I'll be able to provide a further update based on the programs we're looking to implement as a pilot, and then obviously going forward to report back on the uptake as a result. Very happy to answer any questions.
Many thanks, Jade, and also helpful to hear that we'll hear more on the dental side in the months ahead. Opening up for questions and comments for Jade. Tricia.
Sorry, Hein. Wow, Jade. I think that figure around the increase in training practices probably just flipped through. That is a significant increase. And we need to compliment the practices that have put themselves forward, but also for your team supporting them. With that initiative, we can really support and develop a workforce for the future. So it's amazing that you've achieved that in the year.
Thank you. Yeah, the team has worked very hard, and I'm pleased to say that we're leading that on behalf of the East of England region. So our ambition is to try and encourage the remaining practices, which we have received another 8 applications this month. So that work is really taking forward, and our ambition is to hopefully try to support practices. So we've got that 100% uptake across Norfolk and Waveney where it is possible. It also will complement the primary care network learning organisation initiative that we've just currently piloting, and we've got 6 primary care networks taking that 12-month pilot just to see how that concept would work as well. So I will pass the thanks on, Tricia, to the team.
Debbie.
Thank you. I was interested in the section where it talks about pooling, top slicing various CPD budgets to enable sort of system-wide training, because I think that could be really powerful, because in a sense, in terms of sort of integrating the system, if you sit down with people and train together and you're doing the training and learning, it feels a really powerful way to better integrate. Is that something that actually there are further opportunities, do you think?
Yes, Debbie, we have done that in the past. So if we look at the examples where we top sliced last year, it was particularly a big focus on mental health,
Yeah.
SMI and LD. And from the training needs analysis results, we have found that those training needs requirements have reduced this year because we've had that top slicing, we've had that strategic focus of last year. So the priorities that we will be looking at is very much linked to our joint forward plan priorities for the ICS, particularly a focus around population health management, long-term conditions, our elderly care patients as well. So very much working in collaboration with all system partners. And that is generally a principle that we apply across the ICS in terms of that top slicing to make sure we've got that multidiscipline learning environment.
Mm. So maybe we could catch up, because I think there may be opportunities to sort of, integrate some of the training that we do in the local authority, for instance, in social care, to see what opportunities there might be there, which might also give better value across the system, really.
We would welcome that, Debbie. I'll get in contact with
Please
my
do.
colleague Sharon. Thank you.
A very good suggestion. Thanks, Debbie. Any other questions or comments for Jade? Excellent. As I said, Jade, a really useful update. Oh, Mary.
Sorry about that, Hein. Jade, can I just ask, are you part of the discussions that are taking place next week with the dental team and UEA?
Yes, I am.
Fabulous. Thank you.
Thanks, Mary. A really useful update, Jade, and a topic close to everyone's heart. So you have a very receptive audience. Many thanks for the update.
Thank you.
We go to item 12, internal audits report. I think Shepard, you will guide us to that.
Thank you, Hein. I would take the report for this item as read, but I would like to just confirm the status of this report and just highlight the main areas in the report. So this is an internal audit report and was completed by our colleagues from TIA, and the report is for noting here. Members are being invited to note the contents of the agreed report, its contents, the recommendations, and more importantly, our ICB management response and the associated timescales to each of the recommendations. In terms of the content, we do recognize the areas for further improvements that were identified in the report, and we fully accepted all the recommendations. And I'm really pleased that an action plan has been agreed with TIA colleagues, and we are making good progress in most of the areas so far. We have taken steps to really share the report widely and socialize with all the relevant key stakeholders, because we do recognize that the implications of the report are wider and beyond just primary care commissioning. So what we've done so far is the report has been presented to the audit committee 2 weeks ago, and it was well received, including the positive steps we have and we are taking to improve where we are. Progress against the action plan will be monitored via the ops delivery groups with regular update to this committee if that's agreeable. And we'll ensure that this is reflected in the forward plan accordingly. And just to summarize, as you can see in the auditor's report, there are no urgent or immediate concerns that were identified for us to address, but we do recognize and accept the 6 important areas and other recommendations that have been made for us to continue working on and address them at the earliest opportunity, taking into account the everything that is going on at the moment. And these areas are largely in relation to the development of the overarching framework for contract management and monitoring, and also the performance monitoring within our governance structures, not just within the the commissioning team, but as the ICB. And great work has already started and is being concluded, some of it with our BI team in the development of the dashboard, which will be really useful to strengthen our own internal assurance and also external. And again, the work around the all-encompassing contract assurance framework has started, and we are on track in terms of its delivery. I'll probably stop there unless there are any additions, comments, or questions for me.
Thanks, Shepard. Any comments or questions for Shepard? Bill.
Sorry.
Yeah.
I suppose the elephant in the room is that the committee has not been providing clear information in terms of the monitoring of performance of primary care. And I'm slightly concerned that there's no recommendation in that we are owning in terms of what we want to do about the issues in the report from the internal auditors. So where does it say? I mean, it says we're to note the report and that others have provided a structure by which a plan, we're not even being asked to agree the plan. So I would have said that that is part of the issues that the internal auditor has identified. I mean, I do think that also there's other things for the ICB to be clear about what it is that they are asking of this committee. And I think one of the recommendations is they find a clear structure and pathway around their decision making around primary care. So it's not all about this committee, but I do wonder whether we are clear enough about what is the ask. What value are we adding in this committee to the general process if we aren't even included in the solution explicitly to something as large as the issues raised by the internal auditor? I don't know what other members of the committee think, but I do think that we need to do more than just note this report.
I have some views, Bill, but maybe I invite Sadie for some initial thoughts.
Yeah, I mean, I think you know, clearly we were disappointed with the rating. Let's say that up front. I think there's some really helpful things in there, and with the discussion with Tia, they could see that a number of the areas that we had been highlighted are areas that we had on our list, so to speak, for a year since we were previously audited, but due to capacity within the team, capacity within other teams, we had not been able to make the progress on those that we might have wanted to. I think some of the areas we were really pleased to see in there, for example, the business intelligence requirements, the performance requirements that you referenced, Bill, and I know we've had conversations about that before. So that work is now underway. We were asked for a management response. The management response is the one that's in the audit report, along with our commitments of how we're going to respond. And I think it is fair to say that we're in a transitional period at the moment as we start to divide our the forward plans and the plans for this committee and the operational delivery groups between the two groups after approving the delegation agreement. So I don't think this is the last time you're going to see it. There's work ongoing that you will be asked to support and approve going forwards, but we're bringing it here allows the discussion, and we're very open to comments from the committee because we need to be providing you with the information you need in order to feel assured by what we're doing under our delegation agreement with NHS England.
I understand that, Sadie, and thank you for that. And I think you're remarkably clear. But I think part of it is that the committee needs to have an opinion, and I think that's part of the outcome, if I've read it rightly, that the internal auditors raise, and that is not required from this paper. And I personally think that it should be, and I'd be interested in what other members of the committee think.
Yeah, and we're partly ahead sitting on the audit committee as well, Bill, that I think the construct of audits in general in the ICB is that the auditees are members of the executive management team. I have not seen it different in the ICB or its predecessor. So if you want to tinker with that, that I think requires a broader discussion. I think the positive is to have it here in part 1. I think in the past we always had it in part 2, so I think it adds a bit of transparency on where we're at. And I think from what Sadie told me, I think you and I have both made a strong point about the lack of performance data insights, which I think would nurture the kind of debate I think you and I would love to have, and I think would inform the primary care commissioning. So I think maybe I'm a bit pragmatic, but whether we go left or right, hopefully we'll end up in a place as a committee. And I do agree that performance, the primary care commissioning committee needs to then take a view, but I think we're lacking a piece of information to have that in a sort of informed way, and hopefully the actions flowing out of this audit with additional BI resources helping Shepard and Sadie and others, hopefully we'll get those performance insights. So I'm maybe a tad pragmatic about it, but I think we'll get to the place you want us to come to, Bill. Tricia?
So again, I think it's a good discussion. I would be uncomfortable though if there was a split decision-making forum with actions being held at both places. I don't know if I'm explaining myself well enough there. So within the report, there are elements around quality. What I think I would be very comfortable to do is to bring back our plan for quality assurance going forward to the primary care committee for consideration and for comment, and for then essentially giving a sign off to it, which in part may help with what I think Bill is seeking, but I'd welcome his view on that.
Yes, I would accept that. I think that we ought to also do more. So at a very basic level, I think we should accept the report from the internal auditors because they are about this committee. So rather than just note it, but on your point, Tricia, I do agree, and I think that I accept Hein being pragmatic. I think we have to say that, and I accept also what Sadie says, is this is a period of flux and there have been capacity issues and stuff. But I think the committee itself needs to be very clear about the job that it is doing ultimately within the system going forward, and where we add value to the system. And I think that's been, and this I think is really helpful, this report in bringing clarity here, and I'd like us to perhaps think about going forward how we can grow that clarity, and what else we need to consider in order to get to the place where we need to be.
Yeah, I think it's a valid point, Bill, and maybe we can capture it as an action point to come back to later in the year, Sadie. Thanks. Hilary?
Yeah, I was just going to say this kind of discussion came up at the performance committee a number of times, really, about the absence of data and information and the challenges of collecting that information in a robust way. So I think it was something that was already going to be looked at, but it's good to see that there's going to be some focus on that now, because I think it'd be interesting to be able to demonstrate just what is actually happening in primary care, which I think when you're at the coalface you appreciate, but it's not always visible to other people. That's good. Thank you.
Thanks, Hilary. Good discussion and good tractions. I think that's something we should feed off from Shepard and Sadie. And as I mentioned, maybe we can find a hook later in the year just to circle back on. Many thanks. Let's see. Then we go to item 13 for noting. I think Fiona, can you introduce this topic?
Yes, thank you. This is the committee will have seen a copy of the terms of reference some months ago for the Pharmaceutical Services Regulations Committee, which, just to remind members, is the committee that's led by Herts and West Essex ICB, but has representatives from all ICBs in the region at the meeting to make decisions around community pharmacy. For example, change of hours, new pharmacies in line with the pharmaceutical needs assessment. And this is the terms of reference just to reflect the changes that have come into place from the 1st of April to reflect that ICB, cross-ICB representation. There is also one other amendment in the committee terms of reference, and that's around fitness to practice. That is now a function of the committee, whereas previously it was led by NHS England through its professional standards team. So you will see in section 6 that a process has been agreed across the region that maintains the confidentiality and sensitivity of managing that process for pharmacists. So unless there are any questions, I think that's probably all I need to say on that.
Yeah, thanks, Fiona. Any questions or comments on this item? And one practical point, I saw that PSRC will report at least every 6 months to all the ICB ECCC. So my request to Sadie, can we include in the forward planner at the right time some agenda time on what they will report? I think it would be good for us to take note of. Many thanks, Fiona. I see no further questions or comments. That takes us to item 14, the finance report. I think, Stuart, you will guide us through that. And as you're probably aware, you can assume people had a chance to read it, but grateful if you can pick up the key points for us.
Yeah, sure. Hi, I'm Stuart White, Finance Manager at the ICB, and I'm picking up for James because he's otherwise engaged. But yeah, I'll take the finance paper as read, but just a quick summary. So looking at the executive summary, yeah, obviously we don't prepare accounts in month 1. So the first set we've done is for month 2. And we're currently forecasting an overspend of just over 4 million across prescribing, primary care and the new dentistry, ophthalmology and pharmacy areas. It's quite unusual to be forecasting an overspend so early in the financial year, because obviously we don't have much data or information at this current stage, but there's some unidentified efficiencies within the current budget that need to be recognised. This is the same in all other functional areas of the ICB, not just primary care. This is because as part of the 23-24 planning process, a 5% efficiency target was required for the ICB to deliver a balanced plan across the whole of Norfolk and Waveney. Unfortunately, the current efficiency plans don't yet deliver this amount, hence we have unidentified efficiencies. Currently EMT leads are carrying out further exploration into potential solutions. Overspend is broken down on the next slide. So we're looking at slide 2, financial summary. This shows the major drivers behind the overspend. So you've got GP prescribing is currently 3.3 million over. 2 million of this is from unidentified efficiencies. And the balance is the reduction in our largest rebate, which is for edoxaban. This is reduced by roughly 30% from last year, I believe. And then secondly is local enhanced services. This is with the usual PMS, GMS adjustment between primary care and delegated. but it's still showing 6 million overspend, sorry, 0.6 million overspend. And again, this is unidentified efficiencies. And then moving through the report, slide 3 shows the detailed variances, gives you more detail around those. Slide 4 is for SDF, System Development Fund. The slide shows current SDF. We haven't had much of the money from NHS England yet, so there's only small amounts of money and small variances. Next slide, part 5 is delegated primary care. Major driver here is the PMS GMF offset, where we've had to keep the money in delegated primary care because it's ring-fenced budget, but the spend is in the LCS programme. And then moving on to slide 6, prescribing. Again, this is the main variances around the edoxaban rebate and the unidentified efficiencies. Part 7, I think James has provided a detailed breakdown of the DOT budgets because they're obviously new to the ICB. And with this close to the start of the financial year, there isn't much spend, so we're pretty much on plan. And then the last couple of pages are an appendix showing the current risks to the position and to the finances of primary care. And that is about all of it.
Thanks, Stuart. As you said, early in the year, so a lot can happen, but I'm aware of a significant amount of unidentified efficiencies. Questions or comments? Bill?
Yes, I suppose, given that we're already looking at a 4 million overspend, there's no discussion in this report about mitigating that. So I would have thought that we would need to have a discussion about what the committee thinks it's going to do about managing that across the year. Well, whether we think that will naturally even out over the course of the year, or whether there is going to be a requirement for interventions of some port, but I would have thought we would need to have some sort of discussion about what the plan is for managing that overspend, given the ambition of the system to come in on budget.
Yeah, maybe because I see the total ICB finances, which is still reporting an overall balanced budget, but with significant risks to be managed. But I take your point, and I think Stuart did highlight various EMT executives are tasked with finding practical ways to reduce the as yet unidentified efficiencies. But you may recall.
Sorry.
Yeah. No, go ahead, Bill.
No, it's right. So if we're not expected to find that overspend, that's great, and I would hope to see that in the report. But if we are, then and I'm assuming that we are, because it doesn't say that we shouldn't, that I think that we ought to be discussing it.
Yeah, no, I think that's why the efficiencies are unidentified. And I think the question is whether we're allowed to show an overspend. So I think the guidance will become clearer as we go through the year from NHS England. But I mean, currently, we're not looking to obviously cut budgets. We're just highlighting the fact that we're overspent.
I think it's a valid point. I've been assured by Stephen, of course, there's continued effort trying to find more projects to take up the efficiency ask. A slight irony that prescribing is one of the areas that has the best delivery of all the efficiency schemes around. So I think that's part of the element there. But I take your point away, and we should make sure Stephen and James follow that up in the next update. Tricia.
So I'm going to put my hand down. I just wanted to note the system efficiencies that we have in the medicines management space. So I think there's little opportunity to do more in that space. So the conversation needs to be focused on other potential areas, if indeed that's the decision taken by the committee.
Hilary?
So I was going to ask something that may be a stupid question, but is this budget just and these numbers based on historical allocations, or does it reflect the ICB's ambition to put more investment into prevention, upstream care, rather than maybe divide things in the way that they have been historically?
That's a difficult one to answer, but I mean, the 23-24 budget for primary care and prescribing is dictated to us by the allocations received. So that's all I can say, really.
That sounds like more historically driven, Hilary, than big shift between acute and primary care, if that's what you're looking for.
It's historic plus a percentage uplift. It's the same across the country. And our delegated primary care comes with this, the required extra spend, like on additional role schemes. So we get that increase over and above. But other parts of primary care, it tends to be, I think it's between 4 and 5% uplift each year. But yeah, it's based off last year plus a percentage.
Sadie.
Yeah, I was just going to add to what Stuart has said, in that the allocation that we receive is dictated to us, and as you can see, it doesn't quite cover the costs that we have. So we have an instant cost pressure as a result of our NHS England allocation, and I know that James Granger is continuing to raise that with NHS England to see if there is any opportunity around that, albeit that we know we're not unique. There are quite a number of ICBs who are in the same position in the east of England.
Thanks, Sadie. Peter?
Yeah, I guess I don't disagree with the need to identify that there's an overspend and to be mindful of mitigations. I guess on behalf of everyone that's involved in it, I would point out, however, that by my calculation, it's 0.8% of a projected overspend at the moment. So it could swing one way or the other, I guess, is my point. It seems like a lot of money, 4 million, but in actual fact, it's 0.8% against the overall budget. So, personally, I wouldn't necessarily be losing any sleep today, but that's where my nerves lie. Thanks very much.
Well, I know it is not described here, but for the total ICB, there's lots of risks that is not in the plan, but may well happen, and that's, I think, the slightly darker cloud on the horizon. I can tell you as chair of the finance committee. So that's the difficult context, I think, for the ICB, and not just the only NHS organization in the system, but I think ICB carries a lot of risk currently in its numbers. Bill.
Yes, I mean, in the ICB meeting, I did hear an undertaking that it was the ICB's ambition to live within its means this year.
Yeah.
So if that is what we have set, and I don't know what pressures are sitting in other parts of the system, then I don't think it's unreasonable to suggest that unless there's a specific decision made at the centre that a particular part of the system can have an overspend, that we should be looking at it. And it appears that the key driver of the overspend is unidentified savings. Then I think that we ought to be looking at the savings and identifying them.
Yeah.
And I don't think that's an unreasonable expectation from the centre of us. And therefore, I am not clear as by what mechanism would we engage in that, given that it's been presented here. So if we just note it and go away, then what impetus is there for work to happen without us giving the leadership? So is it required of this committee to give leadership, or do we just note it and see what happens?
No, it's not that, but can I take your point, because this is very much a discussion that comes up in the Finance Committee as well, given the risk profile. So allow me at least as one action to talk to Stephen Course. I'm sure the finances are part of the board update anyway, that he spent some extra time on, particularly this point: how will we manage, how will we address unidentified efficiencies and reduce them, Bill? As a practical way, because it's bigger than just primary care, which of course is a big part of the overall budget of the ICB, but not the only constituent part. So good, good discussion, and will be continued. One further question I had, Stuart. I know last year we had a so-called prior year benefit, where in the past we had accrued more for medicine than we had actually spent, because we have to use estimates. Do we have any insight whether we will have some prior year benefits from
I know in the area I really look after is delegated commissioning, and I know in that area we have very limited potential for prior year benefit this year. I'm not so sure on prescribing.
Yeah,
but it's something. It's the question I'll take away.
Yeah, we should see it next month with month 3 results, I think. Good, many thanks, Stuart. And then some points to take away from this.
Thank you.
I'll move to item 15, prescribing report, and usually Michael Dennis would guide us to it, but I believe he is not here, and I think all of his team are in a meeting. Let me just double check with Sadie and Sarah that that's the latest information.
That's correct, Hein. Sorry.
Yeah, and I'm not going to put anyone to the task of standing in for Michael, who's not in his team. So my suggestion is, if people have questions on Michael's report, to direct them either to Michael or to Sarah. We'll make sure it lands with Michael. I had 1 or 2 questions myself, and we'll make sure that either he or one of his direct reports will be at the next PCCC, but I don't think that seems sort of the correct way to handle it at the moment. So apologies for that. That takes us to any other business. Just checking if there's any questions for public that has come in. Sarah, has any question come in from the public?
No, nothing as far as I'm concerned.
We did receive a question from Councillor James Reader, who cannot be at the committee today, but I've asked Fiona to share with us the question or concern James raised and how we intend to respond to it. So can I hand over to you, Fiona?
Of course. Following the presentation at the last meeting around the oral health needs assessment, we've been asked to, what assurance can we give that funding will be available for a dental preventative programme for under 5-year-olds? And would the committee support a funded pilot for children aged 18 months to 5 years within Lowestoft, working with childcare providers and school nurseries, and to allocate UDA activity for children identified as needing surgery-based dental treatment. For us, this is supporting children, children's health has been identified as one of our priorities within the dental work stream, and we will be looking at this and how we might develop proposals as part of our short-term plans to be published in September. We're very aware of existing providers who are already providing these types of schemes, and we're keen to try and support them if we can. So that's where we are at the moment. And I'm happy to go back to James and respond to that.
Yeah, I think that would be good and good to hear. We'll sort of have it, that we have it on our radar screen, and we'll come back to that. Tricia?
So I really welcome this as the Children, Young People's SRO, and the fact that it is one of our 8 ambition areas for the Joint Forward Plan, Fiona. So completely supportive. But going back to our previous conversation around system efficiencies, so this is an invest to save model, essentially. So have we included this in our plans so that we can ensure that any savings generated go against the 4 million that we were talking about previously?
I think that's really important, because obviously what we're doing is by investing in our children now, we're certainly going to be supporting access now and preventing challenges in the future, and that will certainly form part of the proposals that we bring to the committee in September.
Thank you. I mean, even at the very highest level, is a child not requiring to go into the acute setting for a GA to have a tooth extraction? That is a saving to the system, and most importantly, it's an improvement for the child.
Absolutely, yes, and we do have the evidence to support that we are seeing an increase in children going into secondary care for extractions under GA, which is really not where we want to be. So absolutely, thank you, Tricia.
Yeah, thanks, Tricia. Sadie, anything you want to add? Or? No. Good. Well, thank you all very much. That brings part 1 to an end. For those joining part 2, I suggest we reconvene 3:15. To those who will leave us now, I wish you a good rest of your day. See you at the next committee meeting.
Thank you.
Bye.